For our next guest speaker, I would like to introduce Dr. Eden. He will be discussing sudden cardiac arrest. Dr. Eden has a specialty in general and interventional cardiology. He graduated from Ohio State University School of Medicine. He has completed his residency and fellowship at the University of California Davis Medical Center. He also completed a fellowship in interventional cardiology at the Banner Good Samaritan Medical Center in Phoenix, Arizona.
Well, thank you guys for having me. My name is Moneer Eden. I'm a cardiologist here in the Antelope Valley. Been here for about a year or so. And for anyone that doesn't know, a cardiologist is someone that specializes in disorders of the heart. And today's topic is sudden cardiac death and clearance for athletes for participation in sports. So today the topics we'll be talking about are epidemiology, or the scope of the problem, some of the common causes of sudden cardiac death, the changes to the heart that many athletes have that are totally normal when they participate in sports, some of the screening questions and things to look for on the physical exam for individuals that you may see in the office or interacting in high school evaluation or even junior high, elementary offices or classrooms. And there's a debate about the testing that should take place before participation in sports, so we'll touch on that as well. And the last topic we'll touch on is if something does take place on the field or the court, what are some of the things we could do in terms of the responders to help save somebody's life. Just to kind of give you some basic information about how many people participate in sports. It's about 500,000 professional and college athletes. Several million participate in competitive sports through their schools, and then just in like community athletics, it's about another 25 million. So if you put that together, that's about 30 million people, and saying with roughly population is about 300 million, that's about a tenth of the population at any point in time is participating in sports. So fortunately, sudden cardiac death is not very common, although it is extremely serious when it does happen. It's something that in a male you see about 7 out of 1 million people every year, and not as common in females, about one out of 1 million generally in people participating in high school and college athletics. So not terribly common, fortunately. Air Force recruits, it's a little more common, 1 out of 750,000. Marathon runners, because it includes a larger age group. You have older individuals and adults who may have coronary artery disease. That's something we don't typically see in the youth. You'll get more, MIs or heart attacks. And so you'll see more sudden cardiac death in that population. In terms of some of the causes we'll talk about, there's cardiac defects, there's trauma, there's certain things that are not necessarily inherited, but that people do to their bodies, such as stimulants or certain drugs they take that can cause sudden cardiac death. And why is this so popular? Although it's not common, the effect on families and people can be quite profound, because unfortunately people can pass from sudden cardiac death and not be resuscitated. And oftentimes if they have a cardiac defect or a disorder discovered, it takes its toll on the family, because obviously it's a big shock. a person cannot necessarily participate in sports anymore, and you took somebody that was healthy, and now they essentially have to deal with this. And so you can imagine that the effect that will have on families and the community, and that's why, although it's rare, it's obviously something that gets a lot of attention, and should. Also, generally, as just by nature of being in athletic sports, it's competitive. People are constantly pushing the envelope, and as you do that, you tend to kind of bring out certain cardiac defects, and I think that's what we're seeing more of, and that's another reason that this is getting sudden cardiac death is getting more attention. Unfortunately, sudden cardiac death can be preventable, but despite all of our attempts to try to discover this before things happen, there are still cases that, unfortunately, because of the nature of the disorder, we won't be able to catch before it happens. So, in terms of the common causes, we'll talk about some of these. This is just a pie chart of the major ones. The biggest one is something called hypertrophic cardiomyopathy, and that's kind of fancy terms for a enlarged heart. The second one is coronary anomalies, and the heart is a muscle. It has its own blood flow, and there are certain special arteries called the coronary arteries that deliver that blood to the heart. Those are the same arteries that people develop blockages in when you may have had friends or family members that have heart attacks. It's because they have blockages in those arteries. Very rare, but some people can have abnormalities in those arteries that they're born with that can lead to sudden cardiac death. We kind of break the causes of sudden cardiac death into two different categories. There's the actual heart itself or the pump, and problems that may develop. Kind of a long list. We'll go over some of them individually that are more common. And then there's the electrical aspect. The heart is it's a pump, and it all has its own electrical supply within it, and you can develop abnormalities in that as well. So one of the major tests that we obtain in the office or in the hospital to look at someone's heart is an ultrasound. Using ultrasound technology, we're able to look at the heart muscle, determine its size, look at the valves of the heart, and we're able to get a lot of information simply by doing this test, which takes roughly about 15 to 20 minutes. And so I just wanted to show you kind of what a normal heart looks like. Here you can see this is the aorta. That's the main blood vessel that comes out of the heart. And this is kind of the outline of the ventricle, which is your pumping chamber. And this is what the normal thickness of a heart should be like. And this is the cavity where the blood sits. A hypertrophic cardiomyopathy, this is thickening of the heart muscle. And you can see here, compared to the last one, this is all the thickness of this patient's muscle. And as you can see, this is maybe 3 or 4 times the thickness of the last picture we saw of the normal heart. How does this cause sudden cardiac death? Well, as your heart gets so thick, it basically makes your cavity where the blood sits extremely small. And so you can imagine that as it gets larger and larger, less blood is able to be pushed out with every heartbeat. And when you're not pushing out enough blood, your organs aren't getting enough perfusion, and you can pass out if you're not getting enough perfusion to your brain, or you can go into essentially electrical arrhythmias, where your heart can stop because you're not pumping enough blood through those arteries that we were referring to called coronary arteries. Here's a totally separate disorder that actually has nothing to do with the heart muscle, but instead the aorta, the main artery that pumps out your heart, you can get dilation in this area that can rupture at any time. Normally, if you recall, the aorta should be about thickness here, and this one is twice that size, so they're at higher risk for that. Obviously, if we saw something like this, we would watch someone very closely, and in terms of just sports participation, it would probably be sports that have no trauma involved contact. So the last one was dilated cardiomyopathy. That was the opposite of having thick heart muscle, where the heart muscle becomes very thin and weak, which is also a risk factor for sudden cardiac death. Now going back to what we were talking about with the coronary arteries, this is the aorta, and this is your pulmonary artery. These are the arteries that carry blood to all your organs. This is the artery that carries the blood to your lungs, where it can be oxygenated. Normally there should be no arteries running between those. This one here, this is your left main, that should come off here. And this is a schematic or a diagram of this anomaly where it actually comes off here and goes between these arteries. Now when you have an artery running between these two, these are dynamic structures. Every time your heart pumps, these blood vessels are expanding and contracting. So you can imagine that as they're expanding and contracting, when they're pushing up against that artery, and every time they push up against that artery, blood flow, like any pipe, if you squeeze it, nothing's going to go through. And that can lead to arrhythmias and people passing out. In fact, a patient several weeks ago had this condition, or was passing out during soccer, and they got appropriate testing and they were able to discover this. The treatment for this is surgery, where they actually go in and remove that artery and reimplant it in the correct position. This is another condition which you may have seen in movies, or martial arts films. Ultimo Diaportis has nothing to do with a person having an abnormal heart. This actually happens in a normal heart. There's a period of time during the electrical current of a heart where if someone has impact to their heart, it can essentially cause their heart to stop. And here you can see kind of someone kind of filmed a karate tournament or match, and someone had received a strike to their chest just at that right moment. It has to be perfect moment. So this is extremely rare where all those things come together and the person passed out, heart stopped, and hopefully they were resuscitated. So a little more about that. Again, it's trauma to the heart during a certain electrical phase of the heart leads to ventricular fibrillation, which is a fast, irregular heartbeat that the heart can go into. What sports this is common to include baseball players. If you notice, catchers have to wear the chest protection, and one of the main reasons for that is to protect them from this condition. You also see it again in martial arts quite a bit. Not so much in the other sports where there's minimal trauma to the chest. Now, these are actually more common than sudden cardiac death, and fortunately these don't actually cause people to die, but they cause them to pass out pretty commonly. I think we're going to be discussing this one in depth, but heat stress and stroke, neurocardiogenic syncope, which is what we use in the medical terminology for when someone faints, which can have its own various causes. Stimulants, a lot of attention has been given in the past several decades or so to ephedra, certain energy supplements which have that product in them can cause the heart to speed up, and people can pass out as a result of that. Primary pulmonary hypertension, that's when the pressures in your lungs are high, and that can cause you to not only pass out, but you can also develop sudden cardiac death from this. There's a lot of different conditions that can lead to that. Some of them are drugs, some of them are inherited, and some of them are from conditions from playing in sports. If you look at the sports that have the highest proportion of sudden cardiac death, the top two are basketball and football. Why that is, not entirely sure. It may be secondary to the kind of the amount of training, more people participating in those than perhaps the other sports. That's kind of what the data shows. Not all things that we see on an echocardiogram or EKG in an athlete that are different than a normal population is necessarily a bad thing. As you participate in sports, you appropriately, like any other muscle, if you train it, it will become more efficient, it will become stronger, and so there's been plenty of studies looking at individuals in such, endurance sports such as skiing, cycling, crew, running, and even combinations of strength training can lead to your heart becoming thicker. Now, one of the things that separates a normal athletic thick heart from a problematic thick heart is that the function of your heart and the amount of blood flow that's able to sit in the heart chamber remains normal in an athlete's heart. If you have a problem with your heart, oftentimes you'll see other abnormalities associated with it, not just the thickness, and that helps us conclude that this person has an inherited condition, not something just simply from playing sports. And then in addition, some people kind of are more predisposed to getting a thicker heart with sports than others. One person might train and do the same amount of activities and their heart muscle may remain the same thickness. Somebody else might do the same amount of training and develop a thicker heart. Just like anything else, like if someone lifts weights, just because they try to lift the same amount of weights doesn't mean they're necessarily going to get to the same result. So this is kind of a hot, debatable topic that every time you kind of see an event, people get back to this question: is could this have been prevented or detected? Through this slide in here, just to kind of give you the framework. As of now in the United States, we screen our athletes simply by history and physical examination. No testing across the board is recommended or done routinely. In Europe, they do mandate, in addition to the history and physical, a resting electrocardiogram. And we'll touch on kind of how we've arrived at those current guidelines and the rationale. And it's still debatable, but that's kind of where it stands. And just to kind of emphasize the importance of screening, they did a recent post-mortem study on sudden cardiac death in Army recruits, and what they found in the study was that 50% of those recruits had symptoms, or warning signs. So it does do everybody a huge favor by just asking routine questions, and you can prevent a significant amount of sudden cardiac death simply by being more aware and asking certain things. I think this is the most important part of the talk, because I think this is what is the foundation of kind of screening. And so we'll kind of go through all these questions, and if anyone has any questions at this point in time, this is the thing that I would want people to take away the most. So starting with the patient history, if you have anybody with fainting, any type of fainting, no fainting should be kind of just looked over or passed upon, should bring it to somebody's attention so that the medical community, doctors, nurses can at least evaluate that further. If anyone is having chest pain or shortness of breath that appears to be more so than what is appropriate for the activity they're doing, that's not normal. Again, bring them to appropriate attention to somebody so that they can look into that further. If anyone has a history of a heart murmur or detects a heart murmur, it would probably behoove them to see somebody for further evaluation. Certain prescriptions, long list of prescriptions, the medicines out there, you should probably have your family doctor or someone look over them if there's any concern regarding over-the-counter medicines or any type of supplements. You have to be very vigilant in all those things. And it doesn't hurt to ask and just be sure, make sure those are okay for those participating in sports. Family history, anybody with a significant, like any history of early death from a cardiovascular cause, or even a cause, we hear it a lot where, they died at an early age in their sleep and they never figured out why, or that's just what happened, they died in their sleep. That's not normal, and if you have an immediate family member with that, not necessarily like aunts or uncles, immediate family member, I would definitely recommend that you bring that to the attention of somebody before participating in sports. If there's things that run in the family like seizures, even deafness, because some conditions of deafness kind of do have some heart conditions associated with them, passing out in multiple members of the family, again, bring that to the attention of your family doctor or somebody. And then if anyone has any of the disorders we've already talked about, definitely let them see about it. Physical exam, this is more for the care providers in the room, things to look out for. If anybody that's younger than the age of 18 and they have high blood pressure, that's not normal. That should be evaluated further. Certain abnormalities in the pulse and any type of aortic conditions which would be seen on physical exam with diminished pulses or pulses that are not the same in the upper and lower extremities should be evaluated further. So again, no testing is recommended. When should someone go for further testing? If they have any murmur, then I would say just send them for further evaluation or an echocardiogram, just to be sure that everything's okay. Debate kind of for EKGs and echoes in everybody. Part of it has to do with kind of the scope of how many people participate in sports and how would you deal with testing that. And then as physicians, we deal with that a lot because there's a lot of conditions that a lot of the population are at risk for, but the incidence or the amount that you encounter that in a year are not much. So you're left with kind of a resources issue is how do you detect something in so many when it's so hard to catch, essentially. And so because of that, there's 8 million people quoted in that study. And do you do it for everyone? Like, is it just school athletics? There's a lot of people that play in youth soccer that have different regulations. And you can imagine, like I said, if there's 8 to 10 million people playing in sports, how do you really cover that extent of people? And another kind of issue that makes it difficult to screen is that a lot of these disease processes or inherited disorders do not necessarily present themselves all at the same time, nor do they present themselves at the same time in the same person. You can screen somebody, like, and their echo could be normal at the age of 10, and then as their heart grows and their body grows, they get a repeat ultrasound or echo at the age of 20, and then you detect it. So it's not one thing like you can just catch everybody by instituting that everybody have an echo at this time period, because you might miss a lot that way still. And then also a lot of people, unfortunately, have their disorders develop before a certain age. So, if you have a certain age or grade where you want to do this testing or to participate in sports, it might be too late. Another reason that testing has controversy is that, again, just the athlete has their own kind of presentation on their heart develops, and so if you're getting testing on multiple athletes' hearts, a lot of things that could be perceived as abnormal are actually totally normal. And so you could be affecting, the livelihood of a lot of individuals and, kind of creating a lot more fear or unnecessary, distress for the child, the athlete, and their family for things that were totally appropriate. And there's really no great way around that, because unless you're seeing like necessarily a cardiologist, a lot of these things you don't really become very good at unless you're seeing them regularly in kind of a large number of people with these conditions. So I just laid out some examples of things that are totally normal in athletes. So sinus bradycardia, that's kind of the fancy words for having a low heart rate. Normally your heart rate should be like 60 to 100, but most athletes, that have good cardiovascular endurance, their heart rates when they're at rest could be 30 to 40 beats per minute. Like Lance Armstrong, I think they said his resting heart rate's like in the 20s. Because their heart is so efficient, every time it squeezes, it's able to push out so much blood that it doesn't need to beat a lot per minute. Now, if you show that to, kind of a regular, technically, that is a normal heart rate, but for an athlete, it's fine. This just kind of emphasizes that kind of point again. You can see here in athletes, low heart rate, 80% of them, normal population, 20%. Abnormalities in the intervals of your heart, the thickness of your heart, all these are more common in athletes than controls. So this kind of just touches on what we said again. Cost, always you have to factor in cost with, kind of managing your resources, a lot of false positives, false negatives. And again, even if you're negative, that doesn't mean you're not going to have an issue later. Those are all the reasons that the U.S. currently does not recommend screening besides the history. So what can we do if, despite us doing good history and physical, and some might slip through the cracks, what can we do to save lives? Well, a lot of it has to do with just educating the population on, recognizing abnormalities and having good foundations and resources for early responders. And the two basic, foundation is rapid CPR and early defibrillation. This is a defibrillator. It's a device that delivers a shock to the heart. You have your, essentially the unit here that sends the electricity through these electrodes here, which you put on the chest. You guys have probably seen them around. Airports have them, gyms have them. My understanding is that they were at the sports stadiums, but not currently. This is how you develop kind of a school AD program. I took this slide, I think, from kind of the city of Atlanta, and this is what they instituted. So you gotta have a champion in the community, project coordinator. Takes a lot of coordination with the local EMS. So the things to take home, I think, are, again, I think the prevailing theme in this talk is awareness, whether it's awareness of someone and their post-concussive syndromes, or awareness of your children, friends, family, students, that if they're passing out, they don't feel right during practice or sports, that should be taken as a concerning sign, and it does not hurt to have them evaluated further. It's better to be safe than sorry, and just don't assume that it's just from practicing in the heat or just kind of a freak one-time thing. It won't happen again. It's better to be extra sure. And then, like I said, to be aware that CPR can save lives, and early defibrillation can save lives, so that even if we're not able to prevent all these, and we won't, that at least there's someone there in the community that knows how to do CPR, early defibrillation, and if you save one life, then it's all worth it. I think that concludes things.